in effective stimulation, surgical education, and patient safety. And I think those all rank really close to home for everyone in the audience here this morning. So I asked him, can you give me something personal, something that if you're not in the operating room, if we took that operating room away from you and we took your trainees, what would you say? And he said, I said, well, I like playing video games. I played video games all the time when I was a kid, and I still play video games, except now, he said, very strictly and very, very seriously, he does it to keep up his laparoscopic skills. Come on up, Dr. Mara. Where's my
All right, thanks very much. Thanks, Stu, for having me here. I'm excited to be back, and thanks, Brett, for that wonderful review. I'm kind of humbled by it. So this, I'm giving 2 talks. This one was just, I was asked to talk about some sort of pearls of laparoscopy was what I was given. But I talked about the way I decided to focus on was I wanted to focus on the beginning part of the surgery, which is the setup, because I think the setup is the most important part, because if you set things up well, that leads to the rest of the operation going well. So these are my disclosures. So my objectives are for you to understand the importance of OR ergonomics. And my colleague, Dr. Mina Wisa, gave me some of her slides, and she's also one of my co-faculty for the self-injectomy course. So I'm going to talk about why this is important, how we can improve ergonomics in the OR, and then it's going to lead a little bit into some of the challenges with obesity and how they can be overcome. So it's a little bit of a hodgepodge of things. And Confucius said that success depends on previous preparation. Without such previous preparation, there's to be failure. So in the OR, this is my typical OR day. I get to the room early, and I want to make sure that everything is set up the way it's set up. Everything is working, because the worst thing is, like, you get in, you get all your ports in, you're ready to go, and it turns out that the monitors are like all the way over there because it was set up for some other surgery, and then you're getting the nurse to kind of drag it across the room in the field, and then the elbow's pointing the wrong way. All that's frustrating, and it leads to delay, or you go in there and you find that, yeah, like some of the monitors is not working, and then you got to get a new tower. So I come in the room, I turn everything on, I make sure everything is working, because ultimately you're the person who's there in charge of making sure that you have a successful operation. So I position all the lights, I set all my settings, I get all this stuff, and usually I do all this like while the patient is getting in the room, they're being put to sleep. I'm constantly scanning around the room saying, okay, what are little things that I can do to try and basically save time for the operation later on and make sure that things are set up in the way that I like it. So I'm going to make this a little bit interactive. Everyone sort of had their break, and I know people have different surgical practices, but if you spent a day in the OR, my question to you is what hurts? And I want a show of hands. So how many people have neck and shoulders get sore? Okay, arms and hands. Okay, you got a few. Lower back. A whole bunch. Legs and feet. So obviously, I think this is an important issue, because ultimately, if you're uncomfortable during the surgery, then it compromises your ability to do the surgery, and then you end up spending money on physiotherapy and massages and all that other fun stuff. So, and as we know, ergonomics is really important in the workplace, for people who do desk jobs and things like that. And I think it's just as important in the operating room. So what's going on here? What do you guys see in this picture? And I want you to look at the position of the 2 surgeons that are standing. And do you see the difference between person on the right, person on the left? Anyone want to shout out anything? What do you see? Arms, right? Exactly. So the person on the right, that's Dr. Wisa. She's experienced. You see her shoulders nice and relaxed, elbows by her side. That's what you want to be. The operations that we do, I do advanced endometriosis and so does Dr. Wisa, and some of our cases can be 3 up to 4 hours long. So to spend hours in that position, you're very quickly going to get tired. And it's not only important for the surgeon, it's also important for you to be aware of what your assist is doing, because they're the ones who are helping you out. So the assist is in an uncomfortable position. They're not holding the camera right. They're going to be shaking, and that's going to make things awkward for you. And ultimately, if they're getting fatigued, that's where there's a potential for injury to happen. And so I'd be very aware of not only my ergonomics, but I pay attention to the ergonomics of the other people in the room. The other thing I want to point out is I have a Mayo stand that's there, and that's between myself and the scrub nurse. And what I like to do is I like to have all or almost all the instruments that I'm going to use up on there. So again, I'm not having to reach across or reach across the patient and doing this all the time, trying to get instruments. Everything I need is right there with me. I quickly grab any instruments that I need. You guys spot the difference here? Right? Stepping stool. Because you can only lower the bed so much, and especially when we get into obesity. It depends on the surgery that you do. Again, I speak to a lot of gynecologic surgery, and when you're working in the pelvis. And so when you're working in the pelvis, you find that because you're angling down, that your body needs to be situated high, as opposed to if you're doing maybe something such as an appendectomy or taking down adhesions on the anterior abdominal wall, then you need to be down low. So a lot of times you're transitioning from being up on a stool or down on the stool. But for the majority of the surgery, when I do pelvic surgery, I'm most of the time on the stools, and that's usually both my assistants are on stools for this. And so this is something, again, that I set up at the beginning. I get my stools positioned the way I want it on both sides. And so they've actually done studies of this, looking at optimal table height and including the use of stools. And basically what they found is that there's this optimal height where they not only looked at patients or surgeons' discomfort, but they actually did EMG recordings of it. And they found that there's this optimal height where, and that's usually when the elbows are in level with the instruments and relaxed, where there's less activation of the muscles, and patients surgeons are more comfortable. So the goal of surgery is, and this is something to play with, sometimes it varies during the operation, and a lot of times it depends on the patient. So that's what I'm doing is at the beginning, when I'm setting up the patient, is I'm standing on stools, pretending how am I going to feel during the operation. And so this is something that I would encourage you to try and do in your operating room. Now, what's happening here? It's a little bit more subtle now. Look at surgeon on the right versus assistant on the left with respect to their arm position. Yes, I think I see some hand motion. So we're seeing a lot of this going on. And what happens here is there's actually two things that are happening out of this picture that is related to the operating room setup. One is the location of the monitors, and it depends on the monitors that we have available. So and in this setup, we have two surgeons looking at one monitor that's between the patient's leg. And so when you're doing pelvic surgery, the natural setup is that it's hard, I want to show my body, but I was on the microphone. The natural setup is that you have to look at a monitor that's in between the patient's legs. You're having to turn your body. And again, that area creates an area of discomfort because you're constantly having to turn. The other thing that you find a lot is that when and I encourage you to afterwards just to kind of like do this and see what you do. But I find that when you have to rotate your body as well, you tend to dump a lot of your weight all on one leg. And I actually was seeing my physio there about this because I was having discomfort in my foot. And we talked about it and we thought about it, and we realized that actually what I was doing in the operating room when I was doing long surgeries is I was dumping all my weight on one foot, and I was basically just causing compression where I wasn't moving or giving it time to recover. And that was something that I actually consciously had to change in my ergonomics. So having the monitor in between the legs facilitates that. Now, the optimal way to try and prevent that is, so you see the picture on the left, and that's the setup between the monitor between the two legs. The optimal position, if we were to all have it, is to have two monitors right directly across from each surgeon by the legs, so that one surgeon is looking one way, the other surgeon is one way, and ideally, if you have a vaginal assistant or a nurse between the legs, that they actually have their own monitor, that they're looking right in front, because you can also imagine if you have someone between the legs manipulating the uterus, and they're having to twist to look at the screen, they're not going to be comfortable. They're not going to be they're not going to be helping you optimally. Now, this is hard to do because we're oftentimes limited in the facilities and funding that we have in the OR. So not everyone has these MIS suites to do it. So I do my best to try and do it, and I see if there's any extra monitors available. Sometimes I've even had to bring in 2 towers. I said, hey, is there any way that we can bring in the second tower? Because ideally it is the optimal weight for ergonomics, especially if I'm looking at doing a longer surgery. But I recognize it's something that's not optimally feasible. The other thing that you want to look at is the height of the neck, where you're looking. So you're only on stools, but then where's that monitor? Because if you're looking up like this and your neck is constantly extended, again, that's going to create constant strain and create discomfort at the end of the day. And the optimal angle is one that's more relaxed, where your eyes are almost looking downwards. And one of the problems with a lot of the towers that come, so you have with everything's on one tower and the one that you wheeled in, is that those monitors are actually usually on quite a large height. So again, that's something that I have to do at the beginning of my operating room, is I actually have to go down and drop the monitor, and sometimes it covers up your covers up the instruments. Like I can't see exactly what the gas readings are, so sometimes I'll just have to look around just to make sure that's okay. But for longer surgeries, again, I like to have that monitor drop down to an optimal height. So the other thing that's going on in this picture is as we are working in the pelvis and the person's doing this, is they're leaning back because what they're trying to do is they want their arms in front of them because that's more relaxed, but because there's something behind them, and what's the thing that's behind them is patient's arm. So that surgeon is now trying to lean back against the patient's arm and trying to operate their instruments, and they're doing this. So now we got 2 problems, because now you have a surgeon that's not comfortable, and that's making the surgery more difficult. And then you also have the surgeon leaning on the patient's arm, and that's going to create a potential for a problem. And so this is where we get into tucking of the arms. So I have a question for you. So how many people here routinely tuck both arms at laparoscopic surgery? Go ahead. Okay. How many people tuck one arm? Okay, one arm tucked. Okay, and how many people don't tuck any of the arms at all? Okay. How many people want to tuck the arms, but anesthesia won't let you tuck the arms? Okay, so we're going to talk about that. So, because that is like, and it is one of the barriers to it. So tucking the arms, this is the reason why we tuck the arms, is to avoid this. Again, especially with pelvic surgery, it's less needed if, let's say, you were doing an appendectomy where you may be on the side of the patient and not having leaning. But if you're doing any kind of pelvic surgery, then the angle is that you're having to, again, work in the pelvis. And even if I have the arms tucked, what I often find is I'm that pole where you have the drapes on. As the surgery progresses, I find I'm having to push it way back to the head of the bed, because where I'm actually standing for optimal ergonomics is I'm standing right beside the patient's head. And so for me to stand by the patient's head, that arm board can definitely not be in the way. Otherwise, I'm practically sitting on it for optimal ergonomics. And so the positioning involves protecting the arm. So having the arm by the side and using various forms of protection. And this is one of our hospitals where we work, where we have these pads that are sort of roofed so that the arms can sit in, and then the sheets are draped over to make sure that the arms are not dislodged. And then you can even get toboggans that are rigid, basically sleeves that are put in on the side, and that prevents surgeons from leaning up against the arm board when it's tucked in, because that's often a concern. And the positioning of the hands and arms and padding is important for protection against ulnar nerve injury. So this is the problem, right? And you want to tuck the arms, and it does definitely make the surgery easier, but anesthesia says they don't want to. And what it really boils down to is I think having a discussion with anesthesia, and this is something that didn't happen overnight. This was something that was done in a lot of hospitals with discussion about the concerns of both people, the concerns of the surgeon and concerns of anesthesia. And so if you're having barriers, I think the first important point is try to have a discussion with your anesthesiologist in your department or at whatever level it needs to be at, and try to understand what are some of the barriers that may be present. Oftentimes it's just they're worried, well, am I going to have access? Because if that IV isn't working, then I may have to start a second IV, or if we run into a problem, I'm going to have a second IV. So I said, hey, if you would feel more comfortable starting a second IV, I think go ahead and do that, and take the time. I give them all the time that they want to be comfortable in the setup. So one is I say, hey, do you have a second IV? The other thing that they often worry about is leaning on the blood pressure cuff. Because sometimes if you do tuck the arms with padding or not enough padding, that there is a tendency to lean, and then the cuff doesn't go off, and then obviously they're concerned about that. So then you can use rigid toboggans or even bean bags to help with that. Obviously mentioned some of the barriers that these concerns might have, how it appears with surgery, and then how if you are going to lean, the risk of plexus injury. I say don't settle for one arm, because that's always a negotiation. Well, if you do, well, can we just do one arm? It's like, well, it's not just, I just firmly say, I'm like, that's not going to work, because it's not just me, it's my assistant. Both of us need to be standing up by the patient's head, and it doesn't work if we're standing, if the arms aren't tucked. And then when I tuck the arms, I ask them, are you happy? I say, are your IVs running? Is your blood pressure? Because that shows, like me, I think for them, it shows that I care. Like I said, are you happy? Is everything running? And usually once that's okay, then we can begin the surgery. Some other things that you can do, so rubber pads to stand on. The nurses like to call it the princess pad every time I ask for it. I like to be comfortable. So, again, it's like you're standing for 3 hours. You get sore. Avoid the leaning. We mentioned the elbows and gaze. And I think it's important for us to be aware, because I think a lot of times we're not aware, because it happens over time. And a lot of times, and it's just accepted, oh, I had a long day, oh, I'm aching, and we just kind of go with it. And we sort of say to ourselves, and when we focus in on the patient, we're not necessarily aware of our own ergonomics. And sometimes we just say, I'm getting old, and it's hurting or whatever. But I think we need to change this attitude, and in the OR, be conscious. And if you're feeling uncomfortable, if you're feeling sore at the end of the day for any reason, ask yourself why, and is there anything that you can change? Because ultimately, we want to be able to be doing this until retirement and not having to be off because of potential injury. Now, things get a little bit more challenging when we get to obesity. So you guys have an upper limit for obesity. Usually, I ask this in a tertiary care center. Usually it's limited by what the capabilities of anesthesia and your center. But there are certainly, laparoscopy is especially important in obese patients, because they're the ones who are going to have the complications if you do a laparotomy. And so I talked about setting up for success with ergonomics, and now I'm going to talk about setting up for success with respect to obese patients. And I talked about BMI, but it's actually not just about the BMI. There's a better tool, or another tool you want to think about, is the waist-hip ratio. And it's not just what their weight is, but what's that association or what's the fat distribution in the patient that's going to make the difference in the laparoscopy. So which one do you want to do a laparoscopy on, right? These patients have the same BMI, but which is the one that's going to be better for laparoscopy? Obviously, the one that's on the left. So that's something just to think about in your operative setup, and this is going to play a little bit into your port entry. So I talk about breaking down the blood-brain barrier because it's the old joke, right? You know, we're the blood and anesthesia is the brains of the operation. And it's about, again, as I said with the OR setup, when dealing with obese patients and the challenges that we're going to face with dealing with obese patients, to me, it's all about having that discussion. And so I do this, again, at the start of the day before the patient's brought into the room. I talk about the concerns are obviously going to be increased airway pressures in obese patients. And I negotiate Trendelenburg, and I say that for those critical moments. I say, hey, you know what? I'm going to really try and minimize Trendelenburg to minimize airway pressures, but there's going to be a couple times where I'm going to need it, where I'm going to have it. Now, remember, the Trendelenburg does not help with mobilization of the sigmoid colon. So a lot of patients, these patients have a big, huge redundant sigmoid colon, and giving more Trendelenburg isn't going to help with that. The sigmoid colon is fixed down into the pelvis. And so it's good for mobilizing small bowel, but when you have a big redundant sigmoid colon, you need to have something else that's going to help with mobilization. Oftentimes with obese patients, I use a low airway pressure and low pneumoperitoneum pressure. So I negotiate down to 12. I said, hey, if you give me more Trendelenburg, I'm going to work at lower airway pressures because you only need so much to actually get distension of the abdomen. There's other more expensive high flow insufflation systems like the air seal, which can help maintain even lower pneumoperitoneum. And I talk about making breaks. I said, hey, you know what? If pressures are getting high, let me know. I would rather take a break and let the patient recover, to turn off the gas, vent off, than struggle the midway both way through where I'm struggling and they're struggling. I'd rather just have optimal positioning when I need it and then take a break when the time is appropriate. So I have this discussion so that the OR goes smoothly. And these are devices that can help prevent slippage. One of my colleagues really swears by this thing called a paint pad because you can like put people really asleep and they don't slide off for some reason. These are some tissue retractors that you can use. I said, so especially for the sigmoid, oftentimes you need something to retract the bowel as opposed to giving more Trendelenburg. The angle of entry is really important with obesity, and when you enter with the abdomen, so this is again what's going to set you up for a successful surgery, is that the abdominal tissue gets a lot thicker as you get obese, and so your angle is almost straight down, because you can imagine if you look at the entry on the right, if you go aim in at an angle, now you're going through several centimeters of abdominal fat, and that's going to restrict your movement of your camera, and that's going to make the surgery a lot difficult. So as the BMI goes up, your angle of entry ends up being straight down. The important point to remember is that the thinnest point of the abdominal wall is at the umbilicus, and so the entry is not infraumbilical. It's not slightly below the umbilicus. It's not all the way below the umbilicus. In an obese patient, it's right in the umbilicus. And especially if you get these patients with a really, really deep belly button, even if you're just a centimeter off from the base, all of a sudden you have several centimeters of abdominal fat that you're going to go through. And one, that makes it really hard to tell that you're in. And two is that it restricts the movement of your camera and is going to make the surgery. So what I do is I use some sharp towel clips and I actually evert the umbilicus, especially the ones that are really deep, to kind of walk your way along. And you just make a little incision right. So the center of the umbilicus is your center of the incision. And if you do that, even in obese patients, you can just get in quite easily, and then your scope goes in very easily. And if you have that, that's going to make your surgery a lot more easier. Other things for obese patients, if you're someone who's really obese, the umbilicus is really, really deviated. So if you don't know about left upper quadrant, Palmer's point, that's one area of entry. You want to make sure that you empty the stomach because the closest structure to this area is going to be the stomach, and also you want to make sure there's no splenomegaly. So it's a little bit of a hodgepodge, but the more message is that it's all about the setup and before and how you approach things at the start that's going to lead you to successful surgery. So ergonomics, getting the right setup, get to the room early, set up your heights, having that conversation with anesthesia, any challenges of the patient, especially obesity, those discussions about tucking the arms and the concerns, and thinking about your entry, especially with obese patients. And that's it for this talk.
I think we have time for one, maybe another short question.
Do you use basic ergonomics for all entries?
All entries, yeah. Obese or not, because again, that is the thinnest point of the umbilicus. And cosmetically, it's completely hidden too. If you use the very base of the umbilicus, you're not going to even see that incision because it's going to be completely hidden. But it is the thinnest way. And sometimes it's like you just barely have to get in sometimes, and you're already in the abdomen. Any questions? Right? Okay.
Thank you. Thank you, Dr. Mira. I'll let you get your computer there. I don't know, but I was starting to get a kind of sore back sitting there thinking about
things I wasn't doing in the OR that I should be. Thank you very much, and I'm sorry we didn't provide the princess pad for you. So we're moving on to our next, we have a trio now coming up. You see that we're sort of shifting it around. We have some soloists, we have duos, we now have a trio coming up. And they're going to be talking about elevated BMI in the obstetrics patient. How large a problem? Very ingenious question. So I'm going to tell you about our three presenters. We already know Dr. Pinar, our enthusiastic skier and motorcyclist and kite surfer, an obstetrician that is working for the past 25 years up in Prince Rupert, British Columbia. We have Dr. Erica Button. Erica did her medical school in Saskatchewan. She's now in Hinton. She trained under Stu. So she said that should basically say it all, and I think many of us would agree with that. She does ESS and focuses on obstetrics. And it was interesting. I said, well, what can you tell us? You know, away from the MD role, what can you tell us about you that's interesting? And then she struggled, and she struggled. And I was like, you know, you got to give them something. They're going to start searching the audience for someone who knows you, and they're going to give you some details. And then she went on to say that she went on a 6-month sabbatical. In that 6 months, she took over 35 flights. She went to 21 countries. And I thought that was a fairly interesting thing to do, and felt incredibly small and insignificant when she thought that was not too interesting to share. So she's obviously a significant traveler, adventurer, and fits the rural perspective, I think, really well. Then we have Dr. Kirk McCarroll. So Kirk currently is in Revelstoke as a GP anesthetist. I love this. He said, well, I guess, you know, I'm the RCCBC FPA NL. I said, I'll let him know that. So he is the RCCBC Family Practice Anesthetist Network Lead, which in British Columbia is a significant role for the programs in rural surgery that we are trying to establish and are trying to support for those that are already existing. He did his MD in Dalhousie, and this is an important fact, so remember that. Then he came to Prince George to do his family practice residency. Everyone wanted him to stay, and we were disappointed to see him leave, but it makes sense that he's now in Revelstoke with the work he's doing. I asked him what kind of skills, what kind of hobbies he's had. He said, after much deliberation, he thinks that the greatest thing about him that maybe is least known is he's the world's most skilled and disgusting lobster eater. So, and I think that comes from his Dalhousie training. So I'd like to welcome up now the kite surfer, the binge traveler, and Dalhousie trained lobster eater.
Oh, you guys slides in the same time.
I don't have slides.
No, usually not.
I don't have any slides to present today. This talk came about with the planning committee for this conference. What other topics would be of interest to rural ESS physicians, both on the obstetrical side and on the surgical side. So the question that I raised was, within the last couple of years, our institution has been told we have BMI cutoffs. And this started with the obstetrical world and progressed into our surgical world. So I'm in Hinton. It's a town of about 10,000 people. We have a catchment area for obstetrics and general surgery, probably pushing about 30,000. I have 3 specialist surgeons, none of which do any obstetrical anything, no C-sections and nothing in that realm. I have 2 FPAs and 3 docs who do cesarean sections. So after a few difficult cases, our DPAs were quite frustrated and basically sort of sat down and said, I think because we're a low risk site, we need to start looking at some limits. So the limits that we currently have for intra-abdominal surgery and obstetrics patients is if BMI is greater than 45, you're referred to a higher care center. Now, for me, that's quite simple. For a lot of you guys, depending on where you're practicing, that may not be easy. My tertiary care is 3 hours away down a major highway. So not as complicated for us as I'm sure a lot of your guys' practices would be. For any sort of sedation, so like an endoscopy or carpal tunnel, things like that, they really don't have a BMI cutoff, although they've started talking about whether they should be considering that after struggling with a BMI of 56 for an endoscopy with the sedation portion of it. We have a bit of a gray zone, so between 40 and 45 obstetrically, then it's a consult with both the anesthetist as well as one of the docs who's going to do the C-section if required. We have a third cutoff, which sort of came about, again, following some difficult cases. If somebody has a BMI over 40 and they've not had a successful vaginal delivery, then that person, if they want a trial of labor, is referred to tertiary care. I have no evidence to support any of those numbers. I'm not here to defend what has been done. I'm here to open the discussion because we found it quite shocking that all of a sudden there was this hard set limit in our practices. And what do you do with your G6 who has a BMI of 46, who it's probably more risk to send her, to tertiary care and have her induced than to keep her in your community. So this is about opening the discussion about what other centers do and where we should be starting to think about, do we need to be setting some standards? Do we need to be thinking about making everybody a bit more uniform? So I'll pass it off to Kirk, who's going to present you some of the anesthesia evidence. There you go.
Do I need this? What do I need it for? Yeah, well, I'm starting to feel like I was set up here. I didn't realize that this was an opportunity for all of the surgeons in the room to really attack anesthesia. And so, are there any other anesthetists in the room? Oh, no. I got Stu. So if the stoning begins, Stu, I'm going to ask you to come on up here and back me up on this. I figured you were. Okay. Well, so what I'm going to do is try and present some of the I'm going to try and present. Can you get it working for me? And I'll keep talking. I'm going to try and present to you some of the concerns that are related to the obese parturient and for the obese surgical patient, for that matter, and discuss some of the anesthetic considerations as well as some of the postoperative concerns that we have for these particular patients. And then I know this conversation is probably going to go to BMI cutoffs, and I'm certainly happy to go there and talk about that. But my hope is that with looking at this presentation, the focus will not be so much on BMI cutoffs and shipping patients out to larger centers for their care, but rather on providing these challenging patients the appropriate services so that we are able to manage them in our rural centers. And like Nadine mentioned last night, it's about correcting that that discrepancy between care. So that's really what it's all about. So I've got this slide here of the iceberg, and the question we were asked to address was BMI, elevated BMI in the OB patient. Is it a big problem? I'd love to stand up here and say no, it's not a big problem, but I can't make that claim. I think that this is a special patient population that offers us very unique challenges, and we need to think long and hard about how we're going to manage those patients. And BMI is really just a number. As we heard in the last presentation, there's certainly a lot of variability in the number related to obesity, the apple versus the pear analogy. And we know that the apple is certainly a much higher risk situation than the pear. So BMI is just a number that really doesn't tell us too much information. And it's kind of like the iceberg. It's just the tip of what we can see. And lurking underneath that tip of the iceberg, there are a lot of other problems, and we're going to talk about those. So first, to disclose, my colleague, Dr. Pinar here, whatever he has to say, I would believe wholeheartedly. I trusted him with the delivery of our firstborn, and that may affect some of the things that I say. So I'll defer to Marius. So the main messages I want to give to you is yes. I don't think there's anybody in this room that wouldn't agree that the elevated BMI offers unique challenges, and it is a big problem. We do need to address it. That doesn't necessarily mean we need to send out these patients, but we need to look at the care that we're providing these patients. I'm going to go over the risks, a little bit of the risks from an anesthetic perspective, and not so much what you think I'm going to talk about. I'm not going to focus on the difficult spinal or the difficult IV access or those challenges for the anesthetist, but more the broader picture from an anesthetic perspective. And then I'm going to talk about how we should manage those risks. And then I think the BMI discussion, the BMI cutoff is really going to be a multidisciplinary decision as opposed to an anesthesia decision specifically. So with the obese patient, there's a lot of considerations that we all know about. And I've broken them down into here into pre-pregnancy, early pregnancy, late pregnancy, intrapartum, immediate postpartum, and delayed postpartum. And they all offer unique challenges. One of the medical problems that is going to follow your obese patients throughout their pregnancy and throughout their hospital stay, throughout their surgery, is obstructive sleep apnea and hypoventilation. And that is going to be my main concern, and I'm going to talk quite a bit about that. And I think at the end of this talk, you're going to see where some of my concerns lie with trying to manage that specific comorbidity. I'm not going to talk about early pregnancy or late pregnancy. Maybe Dr. Pinar will mention some of those things, but that's certainly not my area of expertise. Intrapartum, we need to talk about C-section risk because these patients are at least 50% more likely to go to C-section than the non-obese patients. So we do need to be prepared to offer these patients surgical treatment. They have difficult IV access. Analgesia is a challenge, as you know. Their epidurals are very challenging and troublesome to work with, and we'll touch on that. I'm going to talk a little bit about postpartum. The risk of postpartum hemorrhage is elevated. I'm going to focus on atelectasis hypoxemia, and then I won't really talk too much about the delayed postpartum risk. I think Marius mentioned their elevated risk of thromboembolic disease and the need to consider anticoagulation for those patients. They're at higher risk for ICU admissions, and they're at higher risk for respiratory failure. So, as an anesthetist, when you come in to help manage a patient with obesity, this is an unusual perspective. And Nadine, you spoke about perspective last night, and you guys are usually looking at the abdomen and wondering how you're going to manage the patient. So this may be a little bit different for you. This is kind of what I look at when I'm trying to manage an obese patient and figuring out how I'm going to establish neuraxial access in a patient like that. So there's a lot of anesthetic considerations. But what this slide shows is in fact, despite the risks and the challenges with this patient, this is a patient population that we can provide very good care to. If you look at this slide, this is 118,000 patients. And and what they did was a retrospective review of 30-day mortality and morbidity in this patient population. And you can see that the highest risk population is not, it's in fact not the obese, not the morbidly obese, but it's the underweight patients that are really at high risk. And that's because we can provide good care to these patients. There's something called the obesity paradox, which is really interesting. And there really should be no discussion at all about those patients with BMIs up to about 40, because those patients actually have lower morbidity and lower mortality than the non-obese patients. So I found that was an interesting fact. And then as you see, as BMI does go up, there certainly is an increased risk of morbidity. Wrong direction. So let's just talk about sleep disordered breathing first. I mean, this is my main concern. Obesity is the main risk factor for obstructive sleep apnea, and when it gets severe, you run into the syndrome of obesity hypoventilation syndrome. And these patients are at really high risk. These are the ones that are found. They're found dead in hospital rooms. They're found dead at home. These patients obstruct. They're very, very sensitive to opiates. And they will obstruct to the point where they develop hypoxemia and develop cardiac arrhythmias and die. So I think the problem, this is the main thing that I think about when I think about the obese population. This is what they're going to die from. So how is this managed? Now, this is a slide, and I apologize, it's quite detailed and small, but this is a slide that I got from our ivory tower at Vancouver General Hospital on how you manage the condition of sleep disordered breathing, sleep apnea. Most of you are probably familiar with the Stop Bang questionnaire. If not, it's a screening tool that's been validated for operative patients that estimates their risk of sleep apnea. So with this flow chart, what you see is at the top, we're screening for patients that are at risk for the problem. Then we're looking in the middle box there at what type of surgery the patient's having. Are they going to need to have a lot of opiates to control their pain afterwards? Are they at high risk of bleeding? Are the surgery is otherwise complicated? Does the patient have cardiovascular disease as well? And it sort of evaluates further their risk. And I'll tell you right now, any of these obese patients with BMIs over 40 that are going to go for C-section are automatically going to be in this high risk category. They're not going to have, if they go for, there's a good chance that neuraxial access is going to be challenging, and they may need a GA section without neuraxial opiates. And managing their pain post-operatively is going to be difficult. They're going to need opiates. So these patients are going to be high risk. The middle part of the flow chart there, I think you can kind of ignore. That talks about the challenges of establishing IV access, getting a spinal, positioning the patient intraoperatively. I don't think this group needs to talk about that. I think as GPAs, it is our responsibility to be able to manage those conditions. And I think most GPAs, they have the skill set to manage these and are quite comfortable managing that. And really what we worry about is what do we do with these patients afterwards. In Vancouver, these patients go to a monitored bed, plus or minus positive airway pressure. So these patients, what a monitored bed means is one-to-one nursing, or ICU care. That's a challenge for most of us in rural places because we do not have ICU beds and we can't manage these patients. I spoke with our regional center in Vernon on how they manage their patients with obstructive sleep apnea now. Not only do they have continuous pulse oximetry and one-to-one nursing to manage these patients postoperatively, they are now doing continuous capnography on these patients so that the nurse can intervene before desaturation. And that's where we're going in terms of standards with these patients. Atelectasis is another big problem. And the purpose of this slide, you can look at the black bars are the non-obese patients and the red bars are the obese patients. And it's quite normal after a general anesthetic for patients to have some atelectasis. And you see there with the black bars, you get a bit of atelectasis in your postoperative patients. But after 24 hours, that atelectasis resolves. What we're seeing in our obese population is these patients, as they lie on our wards, that atelectasis progresses during their stay in the hospital and gets worse and worse. And after 24 hours, their atelectasis is worse than it was postoperatively. So they get worse on the ward. So that's another one of my concerns. And we need the rehab services to, to deal with that situation. If these patients are placed in a room and they're left on their own on a ward where nurses are taking care of several other patients, there's no physiotherapy services over the weekend, there's no occupational therapists to help with their equipment, and there's no respiratory techs to go in and check in on them. the incentive spirometer that you put on the side of the bed is just not going to cut it. These patients need aggressive rehab services, and they need to be available on weekends, and they need to be available on holidays. And unfortunately, in a lot of our centers right now, those services are not available when we need them. Special considerations. How am I doing for time? More anesthesia related. Am I okay? Okay. So I'll skip through this a little more quickly because this is more anesthesia related, but something that you're going to need to consider too for caring for these patients is the mandatory epidural. The last thing that you want is a patient who's got a BMI of 50 who suddenly has a non-reassuring fetal heart rate, and you're rushing to the OR and you're going to have to do a crash GA section on that patient. They've got difficult airways, they're difficult to ventilate, they've got high aspiration risk, LMAs don't work as well on these patients, and they're a difficult cric. So this is a very, very difficult situation. If you have a patient that you're considering for care in your hospital, you want to talk to the patient, you want to get a feel of how they, of their cooperativeness with a healthcare team. These patients should be willing to consider an epidural early. By early, I mean the day before they go into labor. You want to have that epidural in nice. You want to have it before they're uncomfortable and moving around, because it's really challenging to get it in at the best of times. So if you get that in early and you can make sure you've got a working epidural, you've got a lot better chance of providing safe care. Intrathecal catheters. This is something that's being used more and more commonly in the obese population in the tertiary center. And if we're going to start caring for these patients, this is something that we need to become familiar with and we need to start to use. The epidural catheters are, they can be unreliable. You can get unequal spread of local anesthetic, one-sided blocks, and inadequate surgical anesthesia at the time that you need it. So oftentimes in the regional center, they're actually putting in intrathecal catheters that are more reliable for this patient population. I think if you're going to be caring for these patients, you need to be prepared to deal with the difficult airway. I think mandatory or equipment that should be at least strongly considered to be available would be an awake fiber optic bronchoscope in the case where you do need to put these patients to sleep for a C-section. And that may happen because of their difficulty getting neuraxial access. The safest way to secure these patients' airways is with an awake fiber optic intubation. So that should be fairly standard equipment. Invasive monitoring may be needed. If you get a patient who's bleeding, becoming diaphoretic, your blood pressure cuff starts malfunctioning, then it's an absolute nightmare. These larger patients should have arterial lines placed if they're going to the OR, if there's time, and there should be the ability to do that. IV access is difficult, so central access should be considered for these patients as well, and you should have ultrasound equipment and the ability to place a central line to be able to properly care for these patients. The other thing you might want to look at is your OR table capacities as well. Some of the older tables have got cutoff 300 pounds, and we have patients that are beyond those. So as a facility, you need to look at the equipment. Again, consider the logistics. We were talking earlier. I was talking to Ben about time to cut for C-section services. There's a lot of studies that show markedly increased time getting these patients to the OR. There's the logistical challenges. These patients, you need to be prepared with the appropriate lift so that our nursing colleagues aren't injuring themselves trying to rush these patients to the OR. So they need to get a lift into the stretcher and then a lift in your OR. So in summary, patients with elevated BMI are at high risk for multiple complications, including death. And I think I'm glad we're having this conversation because I think it's important to talk about. The BMI is just the tip of the iceberg. It's all the comorbidities that we really need to think about managing. And I think that this decision is not an anesthesia decision. It's not a surgical decision. I think it's a multidisciplinary team decision. And in terms of BMI cutoff, I'll give you my personal opinion is that any woman can deliver in any facility that has the ability to provide the services she might require to manage her likely complications. And with that, I will pass out the stones and you guys can have at me with a BMI cutoff. You can ask me what I feel about our BMI cutoff. But I'll pass it over to Marius here now.
Thanks. I can think that not only did Prince George, but he also came to Prince Rupert and fell in love with my medical student. And she took him away from Prince Rupert. We're so mad at her for that. For the thing. So I'm not going to add much. Yes, I did encourage that relationship. She's lovely. I can't add much to this. This is actually an anesthetic discussion for a surgical group. The question is, should we have fixed BMI cutoffs in our centers or not? And what I can tell you is just one little bit, and that is what we do in Prince Rupert. We have GPAs and we have 2 GP surgeons who cover when I'm not there. They are all uncomfortable with our obese patients. I have never had the GPAs refuse an anesthetic because of weight, and they do not want a fixed cutoff. They feel that they are being forced in this direction, mostly by the specialists who I don't think have much love for the GPAs. And they obviously have the big concern is, well, if we don't practice, what are we going to do in an emergency situation where we can't ship somebody away? My biggest concern is not even the GP surgeons. They are capable. They can do the job. They use the tricks and they often operate with me. So I'm sure their skills are up there. And whenever I do have an obese patient that I operate on electively, I get my GP surgeons in to come and operate with me. And they're not my concern. I'm sure technically you guys can handle that weight. There are tricks involved, and we discussed that earlier on. My concern is the patient. We have to do what's best for her. And obviously the question is, where do all these risks weigh in with when is it better to go to St. Elsewhere? I always keep in mind the excellent work that's done by Dr. Stephen Grabowski as far as rural obstetric services are concerned. Never forget the massive impact of not delivering close to home. When we have 50% native population. I'm telling you, when we have a delivery there, the whole village is in the room. I always wonder about the uncles, sort of go, 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 push, push, push. But that's the way it happens traditionally there. And if we send these women away, it has massive, massive implications on them. And when do you send them away? And how long do they have to sit in Prince George or in St. Elsewhere before they have their deliveries? It's a big impact on the family. And they have it funded. I live in a blue-collar community. Our non-native patients often can't afford going away. They're not funded, and they are stuck. So before we have fixed numbers, we should really consider the impact of the patients of just saying, no, we can't do this yet, send her away. It is massive. I think Kirk has touched the bottom line, and that is it's a discussion that starts way before the delivery, early on at the first prenatal visit, in fact, to try and get everybody involved, including the anesthetist, and seeing what we can do through the pregnancy as far as that patient's weight is concerned, at least making sure that it doesn't balloon. So we thought we would stop here and rather, because we only have very few minutes left, see if there's any ideas from the audience, because we don't have the answer to should there or should there not be a fixed BMI cutoff for our centers.
Yeah, in East River, we've had a lot of discussions that we were advised to pass on all the consultants, not that it's something fixed in writing, partly from the liability standpoint, but then when you cross that threshold, that's change. And what we've said is a guideline for when the discussions should start. So if you might have 40 anesthesia should see the patient with a discussion. So other people have a chance to talk about server. So that's just our comment, and I don't know if I appreciate feedback about whether that is correct. If we have something in a policy, and let's say we have one that we choose to go above that barrier, something goes wrong, there's potential to use it against us. And then the other part, maybe the other speaker comment too, I'm interested in this normal ratio and whether we should also be looking at that as a cutoff or in combination with BMI, other things to look at.
That's a very good question. Does it matter whether they're fair or apple? Yes. How do we measure or quantify that? I do not know. On your first comment, is there a risk to having a fixed one and then having somebody higher than the fixed BMI? Are you putting yourself at medical or legal risk? There's a flip side to that. Somebody that wrote to us when we started an email group around this had said they're actually enjoying having a fixed number, because then they're not the bad guy to have to tell this patient, sorry, we can't do you here, you have to go away. So it makes it easier for them that way to say, not my decision, yes, I'll fix. So it goes both ways. It's a double-edged sword.
Just a quick comment on that, of course, is it's from the patient.
Of course.
We had a case about a year ago in Rebelsville where the whole team agreed insisted on staying in town, so the group has to take a deep breath and manage someone that said, no, I don't care what you say, I'm going to rock up in a merge or my paper. And so the court consent was very clearly documented that she understood the risk.
I think that is essential. The informed consent, having the discussion and telling the patient because of your weight. Of course, this is important because you have to prepare her for an next pregnancy. You know, I think awareness amongst our patient population is essential. So that conversation of, because of your weight, I'm sorry, but these are the risks that we can't get around, including that you might have to be sent out. Recently had a similar thing with a patient with 2 previous cesarean sections who wanted to deliver in Smithers, not in our town, at home with a midwife. And we said, we cannot support this. You know, 2 previous C-sections, you should informed consent. The patient was well informed. She actually signed off on a form and she went home and had that home delivery and said afterwards, you see, it doesn't prove anything, but still, informed consent is important.
I got it for sure, but to me, this is more of a rural issue in general. Like if you look at it from a helicopter view, that this is rational risk taking, and we can try as much as we want to quantitate it with metrics, but still we have to look at it as being holistic risk and looking at it both from the system, the provider, and the patient, because there is a tendency, of course, to take metrics, and then all the holistic risk is delivered to the patient. So we have to be very conscious of that, and I think the 2 illustrations you gave of the patients deciding to do something different is the weight of holistic risk is too much for that patient to bear. So I think we have to incorporate that into our decision making and try to have metrics and parameters to sort of set some boundaries, but still look at rational risk taking and holistic risk for everybody involved.
Absolutely.
Yes, I guess, if I heard everyone correctly from the panel, there is no particular reason why the family physicians who are doing cesarean section can't do these surgeries. They need some mobius retractors, these kinds of things. And if I understood Kurt correctly, there's no reason that the GPAs can't do the anesthesia. It's really a matter of the resources and providing the manpower, the one-to-one monitor afterwards, the capnography. And so, yes, actually, in the end, it's a perennial rural problem. The answer is to offload the risk on the patient and send them down the road, making us feel better and the health authority perhaps spending better. But that's what it's really about. It's not that it's safer, absolutely, for them to deliver elsewhere. It's just safer for them as long as we don't get the resources we need to take care of it. I understand that correctly?
I think you're right. Once again, let's not forget the importance of closer to home delivery. You know, I think this patient very well would have taken the risks and measured it up and said, you know, I want to be next to my loved ones or near to my loved ones when I deliver. And because we are going to get those, we have to be prepared for every single one. The answer is make sure that you use every single resource available. I do my very best for a BMI 50 patient to make sure that I do have one-on-one nursing. No, we don't have an ICU. And I do use all the resources available to me. I baby them. They low molecular weight heparin goes on for 3 weeks afterwards. You know, so I make sure that I baby every single one of them more than I would a normal patient. But I agree with you. There is a point somewhere there where we just don't have the resources and we have to advise elsewhere. I guess we have to wrap up. Yes.
Are you aware of any literature or information that says the weight gain during the pregnancy is an independent factor as opposed to BMI?
Well, what I can tell you is that there is a significantly increased risk of C-section the higher your BMI goes, which is sort of sad. We would love to have them all deliver by vaginal delivery and not have that big incision. We're also worried about the wound incision afterwards and the technically difficult surgery. But the weight gain in pregnancy, I think, is a drop in the bucket. The problem is, of course, that these patients often do not regain their pre-pregnancy weight, and that in itself is a topic of a considerable risk for them. So I think the actual weight gain in pregnancy is normally a drop in the bucket for them compared to their overall weight.
Last question.
In South Australia, where the state health service has determined that all rural centres have a BMI cut-off of 40 with a grace period between 35 and 40. When that was first introduced, we found it incredibly frustrating BMI cutoff as a means by which we get disciplined if we decide, or if the patient decides to step outside those guidelines. And we've already been threatened twice about delivering patients over 40.
That's fascinating. So there's discipline.
Watch out, because you could lose your sense.
Yeah, there is discipline in this particular Australian setup where they go over 40 BMI. If they do it, they get disciplined for that, and that's very dangerous if you have that fixed thing. I must say that if we have a 40 cutoff, wow, a lot of our babies will be leaving town. It would be a disaster if we ever had that strict cutoff. Now, there's a fixed point. Sorry, there's a thing that I said that if it's known in the community that this is the number, there's actually some people that have said then the patients will work towards getting under that, and that might be a good thing. You know, they might be motivated to try and get under that bar. I don't know how powerful that as a motivator is. Sure.
Yeah, I just wanted to let you guys know some of the heat that your local GPAs are under as well. We recently had our conference in Vancouver in October, and we had a specialist come in and wanted to address this issue there as well. And his opinion was that we should have a cutoff for GPAs, not for rural hospitals, just as GPAs. Cutoff should be 40. So that's kind of the pressure that we're under. We're in these specialists that are telling us, you guys, these patients are challenging. You should not be providing services to anybody who's got BMI level 40. When we redesigned our provincial privileging document recently in the spring, we were, again, under a lot of pressure from our specialists to have, within the definition of the skill set of the GPA, a BMI cutoff of 40. And we had resisted and resisted and resisted, and we've actually had some success with pushing back. And we've come up with a document that no longer states that we specifically have a BMI cutoff or an ASA cutoff particularly. We've worded our document so that it reads that the GPA has privileges to provide care to higher risk patients, providing the facilities that they work in have the added abilities to manage the care needs of that patient population. So we've kind of tried to focus it on that. But you got to appreciate where we are a little bit, that all of the specialists that we train with, that we work with and refer to, a lot of them are of the opinion that that BMI of 40 should be a cutoff for GPAs in general.
Quick comment. In Northwest Territories, advice 100% on GPAs. Like when we refer patients out of the far north to Young Life, it's still a GPA. Can you imagine shipping everybody out?
All right, thank you. Well, I think you would agree with me. That topic certainly generates a lot of discussion that I will task you with to continue over the lunch break. But we have one more great talk and an important discussion to come up before lunch. We have Dr. Roy Wyman, who's joining us here. Dr. Wyman is a family physician for over 20 years, practicing in a small rural community back east. He works in the East York area of Toronto. Did you guys get it? Yeah, okay, good. In an academic interdisciplinary family health team. He has worked as a site residency program director and enhanced skills program director for the Department of Family and Community Medicine at the University of Toronto, as a primary care consultant for the Ministry of Health in Ontario. He is presently the Director of Certificates of Added Competence for the College of Family Physicians of Canada. And this is where the discussion gets interesting, and he's going to walk us through this. I think he's taken on a valiant and incredibly vital role to build or build on, depending on how you feel on any given day, collaboration between the two colleges, the Royal College of Physicians and Surgeons of Canada, and of course the College of Family Physicians of Canada, to address ESS training standards. So he's going to share that with us. Now, we had a discussion on the break. Did he have anything interesting to share? He was very excited about some type of camera that he got that meant absolutely nothing to me. But I did get out of him, after all, that he is a photographer, and a very avid one at that. But then he said, you know, that's not very interesting. That's not very interesting. And he said, I guess what something would be that he was in a significant car accident where the car was actually a write-off. And I was wondering, where is this going? Is he talking about rural trauma services? And he said, well, it was caused by a ladybug incident. He wouldn't go any further into it, but maybe we can track him down at lunchtime. Anyways, Dr. Wyman.
Thank you, Nadine, for that glowing introduction. I didn't write the valiant effort part. I did write the rest of it, but thank you very much anyways. And the ladybug incident is a whole other story in and of itself. So I realize that I am in a bit of a tough situation. Obviously, the cliche being I am the last talk before lunch, so I apologize for that, and I'll try and be relatively quick. The other item that I realize is that this is the non-clinical aspect of the whole day. So once again, I apologize for that, but hopefully you'll find it interesting. And the last is that I had the CJRM come across my desk earlier this week and realized that the president's message from Tom pretty much is going to talk about, or talked about, a lot of the stuff that I'm going to talk about today already. So he's sort of preempted me a little bit for anybody that might have read that. So I apologize for that as well. But what I want to apologize for is coming here, and I want to thank Stu and the SRPC for inviting myself and the CFPC to come and to be able to talk today about CACs. So to begin with, CACs are certificates of added competence. So let's get that right out of the way first so people know what we're talking about. So disclosure, I am an employee of the CFPC, sorry, my mistake. And I am the director of added competence. I've been doing that for a couple of years. Before that, I was working there in the other side of it, in the SIFP part of it. And I have no relationship with commercial interests at all. So the purpose of the presentation, really, I'm going to give you a little bit of background. I'm going to give you a background of the work in progress. What are some of the ongoing issues? And at the end of the day, really what I want is to field any questions. And we're probably not going to have time to do a lot of it from up here. But if there are any questions, please feel free to track me down or call me or email me. I'm happy to talk about any of the issues. And tomorrow morning, yes. I will be here till about 9 o'clock, and I'm always happy to talk at that time as well. So once again, purpose is to ensure awareness of the work to date. Some of you might be very well aware of what's going on. Some of you in the audience are very involved in it as well, and I thank you for that. Give some feedback and dialogue back and forth with what's been going on at the college, as well as it relates to ESS at the college. And once again, to learn from you. I have some questions that I have. I need to learn a little bit from all of you to know in what direction we should be going with CACs and ESS in general. So background on CACs. So CACs were produced to recognize members of the college that have a certain skill set above and beyond the standard family medicine skill set, and to recognize those individuals for a variety of different reasons. And just as importantly, to allow for maintenance of those skill sets for individuals. So to be able to track that maintenance is being done over a 5-year period. The first 5 CACs that were done were those that were already Category 1 programs, or programs that have been established with national standards. Emergency medicine has been around for a long time. They already had their own designation. The other ones being care of the elderly, palliative care, family practice anesthesia, and sport and exercise medicine, which had an established program, was not a Category 1 at that point, but at the when CACs were developed, it was determined that should become a Category 1 program and thus have a CAC. So ESS, on the other hand, has been involved in the college ever since we started with SIFP, or what is now called CPFM. For those of you not aware of what those designations mean, SIFP was the previous nomenclature, which stood for special interest or focused practice. That was changed about 2 or 3 years ago to communities of practice and family medicine. And that is a whole separate section of the college that has 19 different committees that represent those individuals that have interests that are a little more focused than your comprehensive family medicine. They include the CACs that I mentioned. They include enhanced surgical skills. They include addiction medicine, but they also include things like prison health, occupational health, chronic pain, developmental disabilities, et cetera, et cetera. If anybody's interested in looking them up, they're all on the college website. And each of these groups have a committee, and the committee has 5 or 6 people on it, representatives from across the country, and really they're there to assist the college with these, what we call the 6 areas of the 6 pillars, and they're in areas of policy, advocacy within the college for members in that area, member engagement, education and scholarships, so looking at how individuals are educated in those areas, CPD and practice support, trying to look at how they're able to help individuals in those areas with their practices. So that's sort of, so there is a section for ESS within that section. Now, furthermore, the CFPC has been involved really through a lot of the work of SRPC with ESS throughout the last few years. And these are the areas, and Tom in his message mentioned most of these. There's the Rural Medicine Summit that has started with a large document, and there was a summit that culminated last year in Ottawa with a full day affair where ESS was one of the topics that was discussed. There are the joint position papers that came out a couple of years ago that had the conjoint work of the SOGC, CAGS, RCPSC, SRPC, and CCFP, and everybody signed off on that. There are the published curricula, the ESS one that came out, I think, about a year and a half, 2 years ago now, and then the OD one that came out a year ago. And lastly, most recently, back in, I think it was September, if I remember correctly, there was the Rural Surgery Forum that was spearheaded by CAGS that I haven't been at a lot of these, but my understanding is this is really the first time that there was this conjoint work between SRPC and CAGS, not to mention the Royal College and the CFPC were there to look at rural surgery and to recognize the position of ESS within that whole environment, and wanting to move forward, wanting to really say, okay, how do we do this together rather than how do we do this in opposition? So this is a lot of the work that is being done, and a lot of the work that has taken us to the point of where we're at today, not to mention the ongoing work of the individuals that have pushed this forward, who I'm sure all of you are aware of. And it's the partnership. It's really the partnership that has got this to where it needs to be. CACs and ESS. So CACs and ESS was approved by the board in May of 2015. This was done at the same time as addiction medicine, and it was expedited. It was really, once again, due to a push by those individuals that really are very passionate about this, and a recognition by the college and the board of the requirement for this, and the recognition that there's a need for this, for community need, to make sure that there is support for hospitals. Hospitals are not necessarily closing because they can't have it, from regulatory authorities, and to give critical credibility to this area of practice, which I think has existed, but I think that having it at that national organizational level, I think just takes it to a whole other level and hopefully helps out. So, work in progress. Where are we at with CACs and the implementation of this new certificate of added competence? So there's basically 3 buckets of work that need to be done for any CAC, and these have been done previously for the other 4, not to emerge already existed. So I'm talking about the new 4 that were established, and this is what's happening with addiction medicine in conjunction with enhanced surgical skills. There is the 2 groups. One is a working group on the assessment of competence, and I'll talk a little bit more about that, but that's looking at really trying to set out the standards of assessment. There's a peer review committee, and that is a committee that's going to be looking at applications for individuals who want to apply to get a CAC. And then the third one is really talking about the programs and the training programs and how do we set up national standards. And I'll talk a little bit about what I mean by category 1 for those of you in the room who are not aware, but I just put it up there just as an outline. So, working group on the assessment of competence. This is a very busy slide, but I'll go through it rather quickly. When we talk about assessment, we talk about CACs, what we're looking at, when we talk about actually assessment in general within the college, many of you might have heard about EPAs, which is what the Royal College is using for a lot of their assessment techniques. What we have used at the CFPC is what are called priority topics and key features. So these are a list of topics that are considered the areas of importance to assess. And the key word in there is the assessment aspect of it. It's not a list of everything that one needs to know. That's a curriculum. It's a list of those topics that can be assessed. And the key features are those aspects of that priority topic that are the important parts that need to be assessed within that topic. So I'll show you some of the ones that have been determined for ESS, and you'll see them, but it's not a list of you need to know this procedure, that procedure, that procedure. It is topics like, okay, post-operative complications. What are the aspects of post-operative complications you need to be looking at? Not the list of these are all the things that could happen, but how are you going to be able to know they exist? How are you going to be able to address them? And those are the things that take somebody from having that added competent skill set to somebody who doesn't have that. The first meeting of this group was done in 2017. And what's really interesting about this group is most of the other assessment of competency working groups were all made up of family physicians, except for the one that did the family practice anesthesia that did have 2 Royal College individuals. This group is, first of all, larger. Most of the other groups were only 5 or 6. This group has 9 members on it. And you can see the distribution of the group is there's 4 individuals who are family physicians that do ESS. And then we have 4 Royal College individuals on there, 2 appointed from the Royal College themselves from the specialty committee, and 2 that are from the other specialty societies of CAGS and SOGC. And then we also have a member from SRPC, which is Stu. And I have to tell you that, and you can ask Stu or anybody else that's been on that group, Brian as well. From my point of view, I think it's been an incredibly collegial work so far, much more than well, maybe not much more, but definitely, well, I'll say much more than I could have hoped. The group has met 2 times for 2 days at a time, and the amount of work that has been done by this group has been phenomenal and collegial and collaborative. So it's been fascinating so far. To develop it, I'll just go through this really quickly. What ends up happening is it is a group. It's a nominal approach. You go through, you ask people their opinions, you take it back, you vote on it, you try and figure out what are the top topics, and then you try and correlate that and make sure it all works out. Most of the time we try and get a distribution across the country, but obviously with ESS, it being much more in the West, we have changed that distribution, obviously. And this committee is going to continue to meet. They'll probably meet about 4 times total and go through each of these topics multiple times until everybody is convinced that they're happy with the results. This is the list. This is the preliminary list. Now, it is not totally complete. This is a draft list. And this is just the priority topics. Once again, not a curriculum. These are just the areas that the group felt needed to distinguish between individuals that have that skill set and don't. And within each of these, there might be anywhere from 8 to 9 to 10 key features that will then delineate what somebody needs to know in that priority topic. Once again, happy to, well, the slides will be shared, but this is still in draft format. Everybody good? Move on. One last picture. All right. Okay, so that's the assessment of competency. So the peer review committee. So the peer review committee is a separate group. So the peer review committee is a group of 5 individuals, and those individuals are those that are going to be looking at the applications from members that want to acquire the CAC. They've already met, they've talked about what it means, how do you determine whether or not somebody has those skill sets, because what we are not going to be able to do, to be perfectly blunt, is for all those individuals that are presently practicing, is to send somebody out and sit there and evaluate the practice and make sure the skill sets are there and make sure that everybody is at a certain level. There is going to be a certain level of trust that individuals that are already practicing and have got credentialing have reached that level of competency, and we're going to have to trust that they are deserving of a CAC. Now, there's certain things we do need to find out. We need to make sure that there is licensure. We need to make sure that the practice fits what we would consider somebody doing ESS. We're going to have letters of reference to show that this individual is doing what they say they're doing. But what we are not going to be doing is sending somebody out to every single individual applying to look and see what that level is. We can't. We just don't. This is what's called a grandfathering process, grandparenting process. We're calling it a leader process. But that is what was done with the other 4 groups, and that's what's going to be done with this group as well. We're still trying to work out the application itself, but the idea is for that application to come out sometime within the next 6 months. Now, there has been discussion about, well, okay, that sounds great, but how can you even consider awarding CACs to individual when you don't have the competencies yet? You know, shouldn't we be sending out the curriculum? Shouldn't we be sending out the competencies first before we even consider handing out the CACs? And there is some argument to be made for that. On the other hand, I would argue that all of you are already practicing. All of you are already doing ESS within your areas of expertise. The CAC is just a recognition of that. So it is not intended for us to come in and say, no, you're not doing it well enough. Our intention is for us to recognize it and for us to make sure that people are maintaining it. The college is not a credentialing body. The college is a license, it's not even a licensing body, really. It's a certifying body. So the credentialing and the licensing is still going to fall on those individuals that do it. We're there to recognize the work that is being done. So once again, more to come on that, but the criteria, as I mentioned, it's going to be more around the areas of membership, licensure, evidence of practice, examples of the practice, minimum years in practice. There's going to be expectation that somebody is in practice for a certain period of time to be able to say that they've been doing it. That there has been maintenance, so somebody has been trying to at least keep up their skills, evidence of dedicated contribution, and referee letters. So training programs. So as you are all aware, there are training programs. There are different, there are full ESS programs, and then there are ones that are only doing operative delivery at this point. And those are the programs that exist. And they've been, some of them are new, but some of them have been in existence for a while. I mentioned category 1 status, and just for those of you not aware of sort of accreditation lingo, category 1, when we talk about enhanced skills program, which is what anything outside of the standard 2-year program is, we talk about 2 different designations as category 1 and category 2. Category 1, is that 10 minutes left, or have it been 10 minutes? 10 minutes left, okay. Category 1 is a program that has national standards, that has a expectation that all programs need to meet, irrespective of their own enhanced skills programs. They are accredited separate, they're accredited within the enhanced skills program, but they get a separate visit where somebody comes and looks specifically at their program. So right now we have 5 of them. The 2 new CACs, both enhanced surgical skills and addiction medicine, will both be getting that category 1 status. We will need to set up national standards, obviously, and that's part of the assessment and competency working group. But they will also be required to fill out what's called a PSQ, which is a pre-survey questionnaire, to show that they are following the overall expectations of any enhanced skills program. So that will be happening, and that's a given. There's no question about that. And basically what that means is graduates of those programs showing that they have that standardized education will automatically get that CAC. Now, they'll need to, they get the ability to apply for that CAC within the first couple of months of graduation. So ongoing issues. So CACs in general, there are other areas of practice that would like to get a certificate of added competence. The college right now is on a bit of a hold, only because we want to just take a little bit of step back, and this is a whole new initiative, certificates of added competence, this whole concept, and there's some individuals that are a little nervous about it. So we're taking a bit of time just to do some evaluation, a bit of research to see, is there an impact? Is there anything that we need to be concerned about? Where do we go next when it comes to the certificates of added competence? When it comes to enhanced surgical skills, CPD is something that has continued to be something that has been mentioned. Obviously, if you look back to the joint position paper, one of the issues are system changes, networks, how do we deal with that, and regulatory authorities, and there's obviously changes that are occurring there, not to mention some of the expectations that are there in BC right now. A lot of that work I see sort of moving forward with some of our partners, with CAGs, with SRPC, with SOGC, trying to work through some of those issues. As I mentioned, partnerships. Practice eligible. This has been another issue that has sort of come forward as to what we mean by that. So by definition, when we talk about practice eligible, we're talking about individuals that are in practice and might all of a sudden decide, you know what, this is an area that I'm really interested in. I don't think I can go back to a residency for a year. I can't leave my family. I can't leave my work. How do I get this set up? How do I achieve this certificate of added competence, this extra level of skill, this extra recognition without doing a residency program? That might be easier for some than others. That might be something that is feasible part-time for palliative medicine. That might be something that may not be as feasible for something that's more technical, like family practice anesthesia or enhanced surgical skills. And that's something that we are needing to look at and figure that out. But that is what we're talking about. We're talking about the practice eligible route. We're still working on that. It will take practice evaluation, so there's cost that is involved with that as well. Next steps, ongoing work of the working group on the assessment of competence. As I mentioned, they've had 2 meetings. They will hopefully be able to finish in the next 2 and move forward with that. We're hoping to get that done sometime in the next 6 to 8 months. As I mentioned, the application for CACs is we're hoping to open it sometime in the next 6 months as well. And then ongoing work with our partners with CAGs and SRPC and SOGC. So that is the end of my pre-lunch presentation. As I mentioned, I'm happy to take questions. I'm happy for anybody to grab me or email me to talk about this further. And that's it.
Overall, I would think it seems to be like really bad. I absolutely get why this is. But if I think of the many GP surgeons that I personally trained up in Prince Rupert over the 25 years that I've been there, it's hard to find people who want to do the ESS. That's a special kind of person to do it. And if we have to step them away to stereotypes, first of all, programs, secondly, they can't go, they've got busy practices and they've got family life, it's impossible. Will this mean that this is the end of a program like ours where we have successfully trained people for the whole region? And if it is the end of the line for us, after my first GP and the local GP, some of the sections once they retire or move away, it will mean the shutdown of a massive, big rural areas facility for these section capabilities. I cannot easily see. I've just thought about the effect that you will have on rural facilities that cannot send people that are trained in local.
No, it's a valid point, and I think that there's a few answers to that. First of all, that's part of the dialogue, right? Like, I am not working, although Nadine seems to think I'm working. East York is a rural, small community. It is obviously not. That's part of the dialogue, and that's why I need to hear some of this stuff. So, on one side, to some extent, I think that there is the benefit to this in the recognition the CAC, the ESS exists, and I think that when we talk about residents and their desire to get extra training, I think having those type of training programs out there and having the recognition of this existing probably increases the push for this in the residency program. Now, what you're referring to is individuals that are not coming through the residency program, now coming top down, and how do we deal with them? So I would have 2 answers to that. First of all, we need to talk. Okay, so that's where really going back 2 slides, that's where the practice eligible route comes in. That's where we need to figure out, okay, are there other ways to do this beyond just going through a training program? So that's the first thing. The second one is, and I know this is a little bit of an unsatisfying answer, but I'm going to reiterate it once again. I'm not an idiot. I know that CACs have impact on credentialing. I know they have impact on licensing. I know that. But that being said, we are not a credentialing body and we are not a licensing body. We are a certifying body. So the fact that we have put a CAC out there does not mean that people cannot still do ESS without a CAC. That's not what I'm saying, right? I am saying that this exists for those individuals that wish to have that recognition. Now, is it possible that certain areas are going to start saying, we need you to have that CAC, we want to see that before we're willing to certify you, not to certify, but to credential you? Yeah, it might be, and I think we're seeing that a lot in, if you go back to EM, most of the major centers in Canada require somebody to have a CCFPM, if not an FRCP, before they're going to let somebody do an emerge. But that is a regional decision that individuals are making. So in your area, is there going to be a requirement that somebody have that CAC to do ESS? Maybe, and that might be the negative consequence of having the CAC, but I want to be clear. The CFPC is not stating that that is a must that individuals have to have it. This is a recognition of an achievement, of an acquisition of skill set, and a recognition of maintenance of that skill set. But we should definitely talk more, though, about the practice algebra route and how we do that, because there is absolutely no intention here to try and scuttle ESS in anywhere in Canada. If anything, we're hoping to help it. So that's not what we want. Does that make sense? Is that fair?
And I really feel we need to give Roy some cover here. The college is really moving in an area.
Wants to pressure from this SRC and from me particularly. The Northwest where you work areas, the ESS there are a bit of a protected law. They're able to be trained by you. They're able to be privileged by you. In the rest of Canada, this has rapidly disappeared. In the province of Alberta, which has the largest ESS community in Canada, there isn't a single faculty that will train an ESS. Because of the issues of accountability, the emerging rigor in medical credentialing, the feelings of personal accountability, all of the kind of training that you described is disappearing virtually everywhere else in the country. And so it was almost with a desperate pass to the college, asking if they could somehow give us a credential, and I know it's not a credential, but it is a credential, that would verify the quality of the training and the competency of the individual in a standardized way that would be portable everywhere. Because without it, we will lose all the things that you are trying to save anyway, but you won't be able to do it by yourself in the face of how medical education is moving. This isn't coming from the college of Roy, it's coming from the SRBC and we actually.
All right. Thank you very much, Roy. Okay, guess what? It's lunchtime. A couple of announcements before we break. One, there were a lot of discussions that were happening that were absolutely wonderful, and I'm hoping that they carry on through lunch hour. I tasked you before we started this second session with something to do over lunch, and does anyone remember what it was? Sorry? Meet someone new. Thank you. Perfect. And so hopefully that networking will continue and we'll start to make Canada an even smaller country. A couple housekeeping items. A key found in row 4 over there earlier this morning. If you need it, just come and get it. Probably not a bad idea to just get it reset for your hotel room by now, but just to let you know that it wasn't stolen by someone who was found on the floor. And then speakers. Throughout the day, if you can make your way at some point to see Jen at the registrations booth, there's a small gift of appreciation from the organizers of this day for all your time and effort. And sometimes we put out with a potential risk of some of your perspectives that you brought. But I think what we're doing here is really putting some really, really difficult questions on the table and having great discussions, and it's quite inspiring. So for lunch, we're going to start breaking up in the afternoon for just a short period of time with the physicians and the nurses. So the nurses in the room, if you want to grab your lunch, and then the nurses session at lunch, and then afterwards it's going to be downstairs in the Lynx salon. And then for physicians, we're going to just stay here and eat, and then we're going to come back into this room for our session. Both of those starting, and then at 2:30 we're going to break again, and then everyone joins together as a cohesive group again. So nurses, if you want to just grab your lunch and head downstairs, and then physicians stick around here, and we will see you all either at 1 or at 2:30. Thanks.